He's training in New York, Memorial Sloan Kettering, as well as he is a professor of nuclear medicine in Uppsala University Hospital in Sweden. He also has some commercial involvements in some of the work in nuclear medicine and molecular radiotherapy, and in some companies, two of which are mentioned here: cancer targeting technologies, and the other one is a venture. No, what's the other company? You have two companies.
Immanex.
Yeah. Okay, so we are running out of time, so let's quickly have him speak to us on the dosimetry. This is a further refinement to some of the fine details that Professor Paganelli talked about. So this is really a refinement of PRRT.
Okay, thank you very much for the invitation and also the presentation. So I presented some of this work in the World Conference in Bad Berka, and also in the 4th ICRT meeting in Ho Chi Minh City. But as you see, so I added some Levi flavor on the slide. And I'm coming from, actually it's a brand new institution located in Helsinki, Finland, and we are part of the World Design Capital. It's third nomination worldwide, and because we perform personalized medicine, and it's part of the design. So we are the only health institution part of that project. And I will speak about the dose planning and calculations for clinical routine, the method what we have developed by ourselves. And in our institution, this is the equipment what we have there. So we have all the imaging facilities, then the PAC system, and because Marian, the dose planning systems were actually developed in Finland with the software, and that's just so we have all the software available. So we have also been focusing on developing dose planning software for radionuclide therapy or molecular radiotherapy, as we call it. And at our institution, we are, besides radiopharmacy and molecular radiotherapy, we also work with oncolytic viruses. We just recently published in Cancer Research some of the results this year. It's coming out, and there are multiple publications. We have linear accelerators and the most modern programs and brachytherapy, and these are the systems what we use. But I won't. This is not title of the topic, and these are the methods what we have available. I will speak a little bit about this tomorrow. So these are the equipment what we have. So this is the cyclotron radiochemistry and the control systems, and then the PET scanner, and these are located within 20 meters of distance. So this is I don't know any other institution in Europe where you have that sort of setup. And these are the real images from our patients and personnel. And so I've been in this field, peptide receptor radionuclide therapy, since the last millennium. We started with indium, and then we started with yttrium DOTATOC. This was in Uppsala, 2001, and so that's my background. And then we have for the Scandinavian countries, we have published guidelines in Acta Oncologica. So the standard treatment is 4 cycles of DOTATATE or 2 cycles of DOTATOC, already discussed in detail in this. And this is the therapy protocol. It doesn't differ from those what were used in Italy or in Germany. And actually, the limiting factors for DOTATATE therapy are this coming from Rotterdam experience, so the bone marrow dose or kidney dose and individual calculation. And the question is that how do you do that? And so there are several options, and I agree completely with what Richard Baum said that there are multiple ways to do this. Nothing is precisely correct what comes to the theoretical background, but we want to get results in clinical practice, and so that is the goal. So we have we have the standard man, and then we have the whole body imaging, and then we want to create 3D patient-specific dose. So for dosimetry, you need two things. You need absolute uptake in your target, and then you have to know the mean residence time. And then for that purpose, you need serial imaging for activity distribution, and then you have to quantificate organs and regions. And you have to know the geometrical relation between these. So you need these S factors. But you have several uncertainties, and calculations are not integrated with imaging. What is the intra-organ distribution? What are the individual patient dimensions if you use standard approaches? And the result is basically that you get almost a real dose distribution. So, and one of the we've been working for the whole body thing was actually this multi-compartmental system. We have actually published that, and lot of constants and create a system, and the more data you have, the more accurate you can handle the kinetics. But it is probably for most of the people is a waste of the time, like running a marathon in New York. So, in order to create a patient-specific 3D dose, you have to measure 3D activity distribution at different time points, and then assume, if depending on the time point, the amount, how many time points you have, exponential clearance, and then assume that the activity is the distribution, what you image is actually the real, and then you can get the real dose distribution with a known uncertainty. And this is important that you have to know where you are, what is your uncertainty. And the radionuclide therapy dose, so all this tilted action is related to Levy from now on. And so for the nuclide, you have to know the radionuclide, so then you have to know the dose point kernel, and with SPECT-CT imaging, you can calculate activity accumulation in different organs, and from counts to activity, you have to calibrate your system, and then you have to measure at different time points, and then you can calculate the biologic half-life. And as Giovanni Paganelli says, all things are important, like the amino acid. Actually, which stereo isoform, is it D form, L form? They are extremely important. But additionally, what is important is the nuclide. And actually, it's also important what kind of lutetium you're using. I'm going to show that. So there are two possibles how you make. There's the direct production method, and then this indirect. And with this direct production method, you have an impurity. It's called lutetium-177N, which has 160 days half-life. So you have to pay attention to that in some cases. It affects on the labeling. So in order to to point those kernels, there's a lot of Monte Carlo data, and you can use this. So this is actually that depending on the SPECT-CT data. So what is the voxel size? So you can actually see from this data, because the red curve is the lutetium-177 curve, point dose kernel. So it's actually the self-dose is the most, this is a logarithmic scale. So it's the most important factor. I won't go into details, but just to, this is the layman. I'm not a physicist, so I'm trying to explain that how do you do this in practice and where the data comes from. And with SPECT-CT, so you have the axial coronal, so you have activity distribution and 4D with multiple acquisition. and then attenuation correction, partial volume corrections, and calibrate your system so that your serial imaging are reliable and reproducible. And for nuclear medicine quantification, you need attenuation correction, the map and scatter correction, and partial volume correction. We are not yet ready there, but then you have to do the calibration with different phantoms, and the better phantoms you have, the more precise your data is. And image fusion, it's required for pixel-based calculations. So you have to, you can usually, if you can use rigid body registration, but it's much better because sometimes the hands might be in different positions. That if you have deformable fusion, and then of course for if you are interested, so you have for special organs of interest, so you have to perform specific registration, and this is what happens as a function of time. And the more data, the more detailed exponential curve you can generate. I mean, we have started with, with eight time points, but now the clinical routine is 3 time points. And for imaging, so this is the whole body SPECT CT, and then these are and we need actually 5 windows. So because this has 2 gamma energy peaks, so these are for the scatter correction, and then the summed output. So this is important. And then when you have to create the half-life, so this is the activity, initial activity, then you generate after serial SPECT-C registrations, half-life map, and then you multiply these, then you get the cumulative activity in megabecquerel hours. So this is the key element to generate this, and how accurate the half-life map is, and this is how precise your registrations are. And you have the cumulative activity map here, then you multiply it with dose kernel, so you have megabecquerel hours, then you have the dose kernel milligray per second per megabecquerel, then you have the dose in grays, and then when you have the anatomy SPECT CT, so you can put the dose curves on a CT registration. And some examples, so this is the Olinda, what is the commercial, and then this is the 3D. So these are our results in 3D, and then this is 3D is our results, and then the Olinda is what is the commercially, or not commercially, but the Oak Ridge software. It's 4 o'clock in the morning, so sorry about at home. It's not. So Olinda versus the 3D. So and another example. So the kidney dose, liver dose, and spleen dose calculated with Olinda, and then you can see that in this case the kidney dose is the same and spleen dose the same, but then there's a lot of variation, because actually in this system each voxel is a number, and each voxel is a number of the dose. And then there are some problems. So the resolution, that how close you are the real distribution, and then there are some imaging and calculation related problems, and then but I would say that the quality of the registration is the most important, and of course if the patient organ movement, if you have deformable fusion, then you can. And about the radiobiology at this point, we don't know anything. And then the other thing is that can we plan radionuclide therapy treatment? So it's patient-based planning, and then can we do pre-planning and dose calculation, and can we project the full therapy dose. And with the pre-planning, we could see that if there is enough dose to treat, and what is the critical organ dose, and decide optimal activity. So we were thinking about this, and I'll give you the answer. This was actually the first patient we imaged with test dose similarly, pre-treatment 3-4 times imaging, SPECT CT whole body, and then calculated, this is the pre-treatment lutetium dotatate dose, and then calculated how much that was corresponding if you would give it 200 millicuries of I learned this from Giovanni, so 200 millicuries of therapy dose, and we calculated, actually this was the first patient, so we predicted that the dose was actually 2 times predicted dose was actually 2 times the actual dose, so it's 11.24, 4.78 here. But because this was the first patient, and I thought, let's see some more. But just before Christmas, last December, after Ho Chi Minh City meeting, the Santa Claus was coming. Santa Claus is coming from. He lives in Finland, actually close to Levi, where we are going to see and visit him, and I learned that with this diagnostic dose, we used lutetium 177 and 177 the combination instead of lutetium 177. And the peptide amount, I checked, I went to the radiopharmacy and checked it, so actually the peptide amount was double. And that was the explanation. But I thought, okay, that this is some sort of, because we did many patients, and there was individual statistics, but now I have, Santa Claus gave me the explanation. And there is a lot of animal data now, and we are working on this matter, as you might know. Okay, so I won't go into convolution. This is, when we see this, so I'll explain this. But then, so this is the treatment planning, so the projected therapy dose and measured therapy dose. So you can see from this data, so you can have to compare all those columns with each other. So they are very close to each other. And I can basically claim that we can predict the therapy dose. My answer 3 months ago was maybe yes. But now I'm more convinced that we can. But we have to calculate what is the correct calibration coefficient. I don't know that. I don't know the numbers. So I need a lot of numbers for that. And these are the, some practical things. So how we do the imaging, how the SPECT CTs, how they look alike, and then some patients. I won't go in detail. So we can, and this is about the program. So even though this is on Varian platform, Varian has nothing to do with this. This is our own. So we can create dose volume histograms and then overlay and different organs. So this is how it works. And then we can also display everything in 3D. This is actually SPECT CT, the skeletal window, and then the tumor doses or kidney doses, and these are some real images. And in clinical practice, so this is the whole body thing. So these are 3 different SPECT CT registrations, and the key element is that how precise you can overlay they on each other, and then create this 3D voxel map. Activity, and then the half-life, and then you are getting the dose. And this is what it means in really practice. I have two examples. So a patient with 2 liver metastases, another patient with 2 liver metastases, and you see that these are first, second, third, fourth treatment, liver parenchyma dose, and then liver metastasis, you see huge variation. Then another, the liver, this is actually probably micrometastatic disease, and then the bulky tumors. And you see that here we have 17, the cumulative dose, and here we have 222. And so this is really individual. Just two patients with two liver sites. And the prediction curves. So this is the ideal curve. So this is the dose prediction curve, predicted dose, and this is the real dose. So we actually overestimate the kidney dose, and then liver dose is actually what it should be, and more importantly, tumor dose is what it should be. And this is some of the data from the experience that you can see that the patients received different amounts of treatment cycles. So we are not sticking on 4. So we can give up to six cycles. And then this is also the dose presentation, how we can generate all these curves. And this is not our own system, so because we have a limited number of patients, so we are collaborating. We cannot generate. Finland is a small country by population, so it's like same amount as Singapore, 5 million, and we have 5 million people, and then. So, but we can do this calculation. So if we have a FTP site, and we can if you have SPECT CT data, so you can load in SPECT CTs on DICOM format. So we can do the fusions and calculations for Helsinki, and we have these are from external. So we are doing this work for some groups in Italy and in Australia and so on. So we can collaborate in this matter with all interested sites. So this is the what I showed in Ho Chi Minh City. So the method takes to calculate one set. It takes now 15 minutes per patient. It took 2 days when we started, but now it's 15 minutes. And own experience is 44 in 16 patients. And we get reliable individualized tumor dosimetry in any geometry. And about intra-organ distribution, also bone marrow. There was bone marrow data, and also dose planning seems to be relevant, and at least so far. But we are looking for larger numbers. I want to get real numbers in this. So these are small numbers, and I thank you very much for your attention. Just to these are the physicists who collaborate, who generate all this, and this is our lead shielded therapy room. We have 2 of those in the patient hotel. So we don't need any special ward. So they stay there, and third ISRT is 7th ICRT. So this is, and it will be in Levi, and you are all welcome there. So I can give you additional information if somebody is interested, and this is how our institution looks like. So we have all that stuff in one building. That's all. Thank you very much.
Thank you, Professor Kairemo. It's tea break time. Any questions? If not, then we'll talk to you privately in the tea during the tea. So it's a social update for you now. And we see you back here at 11 sharp, 11 o'clock.